Thank you very much. So it's really great to be at yet another National Thrombosis Week, and we have had over 2,500 delegates sign up. So it's really great to see you this morning. I'm sitting in my office at St. Thomas's, and you can see some idea of the view I have. I'm sitting in the white building on the right of my first slide, looking over to the Houses of Parliament. And just for once, the Houses of Parliament have been very helpful to venous thromboembolism. And through some of their work, we actually, as a nation, do lead the world in VTE prevention in hospitals. But despite all that, things are not perfect. And I am going to talk through some misconceptions that exist around venous thromboembolism. So I think one of the issues is that there's lack of global awareness of venous thromboembolism. If you meet people on the street anywhere in the world, they'll talk about heart attack and stroke. They know what they mean. That's not so true for VTE. A little bit about hospital-associated VTE, and lastly, where we are in diagnosing VTE and some of the problem areas that exist. So this is a well-known slide. This is talking about the fact that VTE is a leading cause of death worldwide. And one of the issues with venous thromboembolism is that we don't actually know the exact numbers of cases, because we know that cases get missed. If somebody drops dead and very suddenly in their 50s, they will often have on the death certificate myocardial infarction. They won't be thinking about the fact it could also be a pulmonary embolism. And we no longer do enough autopsies to know what everyone dies from. So it's a best guess on many death certificates. And I suspect we're missing many types of VTE. Where I want to take you to is the work that the WHO does every 2 years. They look at the global burden of disease and show us what people are dying from. And of course, it's changed vastly over the last 30 years in that it used to be that the major cause of death was communicable disease. Nowadays, it's non-communicable disease. And non-communicable disease is really on this graph, which is giving the ages on the bottom right up to 95, and then the number of deaths up the side. Non-communicable disease is in blue. And you can see non-communicable disease is diabetes, it's heart attacks, it's cancer, and somewhere in there, it's also VTE. And if you look at the early years, we've still got issues with communicable disease. This is the last global burden of disease that was produced before the COVID pandemic. We're waiting for the WHO to come up with the global burden of disease for the last few years, and I suspect it will look different with COVID on board. But the key message of this is that non-communicable disease, which includes VTE, remains the #1 killer in the world wherever you go. It's true in low and middle income countries. And if we actually dissect down, we know that the number of deaths due to thrombosis is growing. So back in 1990, when they did this exercise, 1 in 5 deaths was due to thrombosis, by which I mean heart attack, stroke, VTE. And then back in 2010, it was 1 in 4 deaths globally. And this table just walks through the facts as we know them at the moment. So you can see that ischemic heart disease, well, we've got the number of thrombotic conditions per 100,000 population, and there's an instance there of 1,500. much lower rates of venous thromboembolism, if you can see on the far right. What we also have in this table is the fact that we're looking here at disability adjusted life years at the bottom. And so that's the amount of disability that's affecting people's lives. And you can see it's not available for venous thromboembolism because there's just been less research. I hope that with Thrombosis UK and World Thrombosis Day, which is the global organization equivalent to Thrombosis UK, this will gradually change as we increase pressure on people like the WHO to consider looking at these areas. So if we look at the size of the problem, the WHO has done some statistical work and has come up with the statistic that hospital-associated thrombosis, that venous thromboembolism from hospital admission, does cause an estimated 10 million cases a year. And if we look at all of the cases of VTE that we see, we know that hospital-associated VTE accounts for 55 to 60% of all cases. So it's the major cause of death and morbidity due to VTE. And the definition of hospital-associated VTE, I think, as we all know, and it's really come from the UK, it's having a VTE in hospital or up to 90 days post-discharge. And this causes a considerable burden of mortality, which is much higher than the combination of breast cancer, HIV, and road traffic accidents, and more deaths than hospital-acquired infection that figured strongly in the newspapers for many years. And then starting just to make you think about how VTE gets missed. So there was a study done in Scotland where doctors were asked, it's about 20 years ago now, doctors were asked, what did they think the patient had died of when they died in hospital? And then they did a post-mortem. And for every case where the doctors thought that the patient had died of VTE, there were another 2 cases where they thought they died of something else. And in fact, they died of a VTE. So we know it's difficult to diagnose death due to VTE. And I think that we all recognize that the problem with VTE, we get death, we've got a rate of recurrence of about 30% at 10 years if you have an unprovoked event. About 2% may end up with chronic pulmonary hypertension. We've got post-thrombotic syndrome, and we've got this issue that people get symptoms and morbidity such that they can't work. So it's the #1 cause of disability-adjusted life years after hospital admission in low, middle, and high-income countries. And then there's the economic burden. So these are very old figures now, and they're trotted out every time we talk about them. So 64 million on the treatment of VTE, probably more now because this is coming from 2005. We spend 400 million on the management of varicose ulcers. And someone had looked at medical legal claims, and it was about 80 million up to 2005. So we know if we give patients in hospital thromboprophylaxis, we're preventing them from having VTE events, we're decreasing the risk by at least 50%, probably more in the surgical patients. And NICE have done all of the sums on that and shown that it's highly cost effective. We are saving money by reducing patients going to hospital with events. And we also know with our systematic approach, so the fact that when you come into hospital, you must have VTE risk assessment and appropriate thromboprophylaxis according to NICE guidance, we have reduced the rate of death in the 90 days after hospital admission. So really wonderful that in NHS England, we've had this long-standing systematic approach to VTE prevention. Wales has its slightly different system. Scotland doesn't have the same mandated demands. And there really is no other country globally that has got this type of data and this type of approach. And we should be very proud that working with the politicians, we have this system in place. Although I know it's irksome to risk assess someone when they come into hospital, but you're preventing further events. And there is now a lot of work going on to try and get patients coming into hospital to know more about VTE. So this comes from World Thrombosis Day. This is from their website, and they are just talking through the facts. So it's out there at long last. I've today got some new data from NHS Resolution, which is our medical legal side of the NHS, and they are doing a press release about this in the week, and it just brings us up to date with how much money we are spending on dealing with medical legal claims associated with hospital admission and VTE. So here we go. They'd look back from the 1st of April 2012 until the 31st of March 2022, so 10-year period, and they've looked at the 687 claims they have had related to VTE across the clinical negligence indemnity scheme. And that means that each hospital pays insurance, because if a patient sues them, they have monies and lawyers in place to deal with the issue. So we've got 687 claims. 60% of the claims were settled with damages, and 40% of the claims didn't receive damages. So the majority of the claims they're paying out for, and the amount that they've paid out for over the last 10 years is nearly 24 million, which is an awful lot that could have been spent on salaries and other good things in the NHS. So where are these claims coming from? And if I'd asked you to guess, I think most people would have come up with the problem of orthopedic surgery. So orthopedic surgery leads in the claims. And then we've got emergency medicine, and then we're going down general medicine, surgery, obstetrics, even hematology is in there, right down to thoracic medicine. So when we look at the causes of the claims, the biggest group, 10.6%, were related to a medication error. And we know that from Getting It Right First Time survey, looking at what was happening in hospitals, that the common cause now is the same, that missed doses of low molecular weight heparin or the wrong dose of low molecular weight heparin can lead to problems. So there was failure to prescribe or administer an anticoagulant at all, failure to carry out VTE risk assessment, and an incorrect dose of anticoagulation administered. And this is in a system where everything is switched such a way that the pressure is on the medical staff to deliver VTE risk assessment. So this is one of their slides. Let me walk you through the story. This is a 55-year-old man who presented at ED with a 3-week persistent lower leg swelling. Surprise, surprise, 3 months previously, he'd fractured his tibia and received care. And he'd had a swelling after the tibia, and he'd been told that it was likely to be gravitational edema following the recent fracture. When you've seen an ED, they noticed that his calf was 2 centimeters greater in circumference, and his Wells scores too. And the patient was referred for a D-dimer and a duplex ultrasound. And of course, the D-dimer was elevated, and the ultrasound showed a deep vein thrombosis, and he was started on anticoagulation. And they went back to try and defend the GP, and they established that the triage call to the general practice was not well documented, and no one had thought to do a well score, and there was no evidence of safety netting. So they felt that this was deemed to fall below an acceptable standard of care, although causation wasn't proved, but this patient got a payout. So it's a reminder, and this is the guidance NHS resolution are presenting, that always important to take a detailed clinical history and write it down. Write down pre-test probability of VTE. Use VTE risk assessment tools if someone's in hospital. And I think that all the others is absolutely true, and that this point 6 is what I would like to concentrate on. Clinicians to attend multidisciplinary training programs supported by Royal Colleges and Health Education England, with a focus on reducing diagnostic error and implementing existing national guidelines and recommendations. And I think in this case, no one thought about the fact that the patient might have a DVT. There's a touch of that in the assessment in the general practice. And I still think that we've got major problems with diagnosis of VTE. Now, we have fabulous things in place. So if you think someone has a DVT or a PE, you would do a modified or a simplified Wells score, and we know what symptoms and signs we would be looking for. And we know about the natural history of VTE. So if we were to summarize all the data, we know that when you have VTE, about 2/3 will present as a DVT and 1/3 as a PE. And we know that if we've got a proximal DVT, many of them will get a PE. In fact, if you were to run a scan on most of them and look very hard, about 40% of those with DVT will have evidence of tiny PE. And the problem with PE is that 10% are fatal within the hour, and 5% will die later. So we know a lot about PE, and we have this fantastic PESI score that most of us use so that we can say this patient is low risk, this patient is intermediate risk, this patient is high risk, and we can put them down the correct treatment pathways. Low risk would get anticoagulation, intermediate risk would probably be admitted. There might be just some discussion about thrombolysis, and obviously high risk would be getting systemic thrombolysis. And we've got this PE pathway. So we're not short of really evidence-based guidelines. The problem is that you have to get yourself in the pathway. So let's just have a look at this patient. This is a 19-year-old. Previous asthmatic, started on the combined oral contraceptive pills. Now, all of us know with the combined oral contraceptive pill, it increases your risk of VTE. 2 months later, becomes increasingly short of breath. She was treated for asthma in her local intensive care unit. She was discharged, but she was still very short of breath. She was readmitted to the ITU, but this time was considered to have a panic attack and referred to the psychiatrist. She was discharged, she collapsed at home, very short of breath, and she saw another admitting physician who thought, perhaps I need to do a D-dimer here. Did a D-dimer, enormously high, had a CTPA, multiple pulmonary emboli. So this is a case where no one was thinking about PE. And this poor girl, she's under a clinical psychologist who is handling her post-traumatic stress disorder. So the problem from my perspective is that we have excellent diagnostic pathways, fantastic state-of-the-art treatment, but many patients aren't hitting the suspected VTE pathways. So when you look in the textbooks, what are they saying? What are we teaching our medical students and our student nurses? Well, it's usually a quick lecture, and they usually get told about shortness of breath and chest pain, pleuritic chest pain. They might get rapid heart rates and increased respiratory rates. And always they mention coughing up blood, hemoptysis, but hardly ever do we see that. Certainly not at presentation. And then DVT, well, swelling in the leg, change in colour and pain. So when we look on the internet, what do we see? My goodness, the pictures out there. So if you look at those pictures, that's more than DVT. That picture on the bottom left, look at that right calf. That's post-thrombotic syndrome. That person has had multiple VTE, and now they've got pigmentation and scarring and eczema and permanent swelling in their leg. That is not a new DVT. And again, we see this type of picture for a DVT, but is this actually true? So I've already reminded you that doctors miss pulmonary emboli in hospitals because they often don't think about them. Well, let's look at other evidence. So the other area where we've studied DVT greatly is in patients after surgery. And this is a study where they looked at all patients after they had a hip and knee replacement and looked for symptomatic and asymptomatic DVT. And you can see that when we look at the hip studies, 2.7 were symptomatic, but 13% were asymptomatic. So you can have a clot that causes no symptoms at all, and after knee-matic, and 38% were 80% of DVT being clinically I'm just taking you to the patient website for which is NHS Choices, and I want to show you what it says there. So it says throbbing pain in one leg, swelling one leg, warm skin around the painful area, red or darkened skin around the painful area. Now this sounds more like superficial thrombophlebitis. And lastly, swollen veins that are hard or sore when you touch them. So this is describing the symptoms of superficial thrombophlebitis. And I look over to the picture, and for me, I can see swelling in both of those legs. You can see the marks on the legs where the socks have been, and there's quite a lot of skin changes on the right leg. And for me, this doesn't look like a new DVT, but it looks like someone's had multiple problems in the leg. This is a real shame. Can you move to the next slide, please? Because back in 2017, they did say what I would agree with: pain, swelling, and tenderness in one of your legs, heavy ache, warm skin in the area of the clot, and redness of the skin. But at the top it says there may be no symptoms in black. Next slide, please. And it would say that because I wrote it. When you look around, some of the websites are pretty good, to be fair. This is the Mayo Clinic, so they talk about shortness of breath and chest pain. And they also mention a common problem, which is fainting. So when you have a clot, then you might faint because of the reduced flow to the heart. Next slide, please. And then they also mention all the other ways that a pulmonary embolism can present. So a cough that may include bloody or bloodstreaked mucus, rapid or irregular heartbeat, lightheadedness or dizziness, excessive sweating, fever, often missed in pulmonary embolism and DVT, and then points out that you might also have symptoms in the leg. And you might, if you are really short of oxygen with a big pulmonary embolism, have clammy skin and cyanosis. Next, have ongoing issues with getting pulmonary emboli and DVT being diagnosed. They're being not up to date, and how DVT, the websites aren't helping. We need to have a new program of educating patients. And healthcare professionals. I utterly agree with them. Thank you so much for listening. I'm sorry about the IT problems. Thanks. Back to you, Andrea.